This is our first time doing a CME conference in an area like on the West Coast or an area, so we didn't have that much in the way of ability to cross-reference with the CME office in Seattle, and so we're going to make the best of this and learn from one another. So I'm really looking forward to learning from everyone in the room. I'll present what I know, and so I have about a 45-minute presentation, and I entitled it Heart Sick or Heart Sync. Heart sick means how the patient experiences things, and heart sync is sometimes how the doctor experiences things, because you see a patient's name on your list and your heart sinks because you know that you have no idea what you're going to do when they come in the room. So I'm going to talk a little bit about the difference between functional and structural autonomic disorders, which is how I think about the autonomic nervous system diseases. So this particular study, this particular CME event was sponsored by the MSA Coalition, and I thank the MSA Coalition for their funding. And also, we have funding from an Advancing a Healthier Wisconsin endowment, which pays for Karen's salary and allows us to do these conferences around the country. So I'm going to talk a little bit about the classification and definition of functional and structural autonomic disorders. Paula is going to spend some time on structural disorders this afternoon, so I'll only spend a little bit of time on structural disorders this morning. I'm going to talk a little bit about comorbidities and functional disorders. I'll spend a fair amount of time on approach to functional disorders and orthostatic disorders management. So we'll start with classification and definition. I'll start with a case, which is a 78-year-old man brought to the emergency. And since there's so few people, let's just have very informal. Interrupt, questions, conversations. Okay, and then for the patients, I just want you'll understand a little bit about, so MSA and POTS are two completely different types of autonomic disorders, and one is structural. We consider structural and functional. I'll explain what we mean by that. So this is a 78-year-old man brought to the emergency room for a fall. He has no lightheadedness. For the last year, his gait's been slowing down and his handwriting has been smaller, but he's really not complaining of much. The family says his memory's been failing, and the usual emergency room evaluation doesn't show much. So he's on a few medications. He's on an ACE inhibitor. He's had prostatic hypertrophy for the last couple of years, so he's been placed on an alpha-1 blocker. He's been severely constipated in the last year. And when you examine him, as a neurology resident going down to the emergency room, you find, first of all, that when you stand him up, his gait freezes and he nearly falls while walking. And a very good resident did an orthostatic pressure, and his blood pressure was 180/80 lying for 5 minutes. And then when he stood up, his pressure dropped to 100/60, and his heart rate did not change. So the first question I want, just a very brief presentation. The first question is, which organ systems are affected? And so let's just think through. So if we make this into one disease, which it may or may not be, but if we make it into one disease, then clearly he's got the motor system affected, so neurologic system. His cardiovascular autonomic system is very likely affected, and his bowel, if he's constipation for the last year, and his bladder are affected, and he's been diagnosed as benign prostatic hypertrophy by a well-meaning urologist who didn't really look at the bigger picture. So vascular, bowel, and bladder, this summarizes this. But the important point is not so much what's involved. The important point is, what did the resident or ER physician have to do to get to that knowledge, which is stuff that's not normally done in the ER. So you'd have to measure an orthostatic pressure. And I think, by definition, anyone with a fall in the ER should have an orthostatic pressure done, but that's not the routine. And asking about bowel and bladder under your systems. So these are important points. The second question I have for you is, would you consider this to be a structural or functional disorder? And for the patients in the room, for now, just think about functional disorder, software, structural disorder, hardware, like a computer kind of thing. This is a structural autonomic disorder, and it's pretty easy to tell. You have lots of findings on your examination, but the symptoms are hard to elicit. In fact, you have to ask the family about symptoms, and the patient says, "I'm fine." He denies lightheadedness, and this is pretty typical in a structural autonomic disorder. So let me compare structural and autonomic disorders. So with a structural disorder, oftentimes you have to elicit the complaints from the family. With a functional disorder, the patient has a lot of complaints, a lot of issues, which are, by the way, I want to emphasize, are all genuinely experienced issues, but they are overwhelming the patients. On a structural disorder, you have a lot of examination findings. On a functional disorder, you may or may not have. For example, you may have POTS on your autonomic testing. We understand the pathology of structural disorders, at least imagining it. We can understand what's happening in the brain, whereas functional disorders, and that's where our research is right now, is trying to understand what is actually causing the problems the patients are experiencing. If we look in the autonomic lab and do things like a cardiac response to deep breathing, cardiac response to Valsalva maneuver, typically they'll be preserved in a software functional disorder, whereas in a structural disorder they'll be impaired. A tilt table test will typically show two very different disorders. Orthostatic hypotension, a structural disorder, which Gibbons just published has a very poor prognosis just by itself. Postural tachycardia you will often find in a functional disorder. If you measure standing norepinephrine levels, they'll be the opposite. So a lying and standing norepinephrine level will tell you whether the autonomic nervous system is responding to a stand adequately. And in a structural disorder, that's frequently will be reduced. Either baseline will be reduced or the change from baseline to standing will be reduced. In a functional disorder, you'll frequently have an increase in norepinephrine responsiveness, meaning that the autonomic nervous system is hyper-responsive to the stimulus. And so we could maybe make up something, a hypothesis about fundamental physiology, meaning that in structural disorders, perhaps the system in the brainstem that's supposed to communicate with consciousness in some way to bring these symptoms to light is failing. Whereas in an autonomic functional disorder, you have the exact opposite, which is that what's supposed to filter out the information is not filtering out the information, so that way too much information is reaching the cortex.
So actually, I'm going to be doing talks on headaches,
yeah.
And the headaches can be seen obviously in both.
Yeah.
However, the most common headache that I deal with in neurology is migraine,
yeah.
And 10% of them will actually have syncope and will have orthostatic hypotension. So I would argue on that point that you have on the
yeah.
table testing that you can, it's spectrum. So it
yeah.
depends on the function. So
yeah.
they have spectrum, they can have orthostatic hypotension.
Orthostatic intolerance. Very, very few have orthostatic hypotension.
You're absolutely right, but you still can have it. So it's huge,
right,
it's a spectrum. So because you're saying it's kind of, black and, white on that point, and I would say
yeah.
spectrum, so I would put, yes, more common in postural tachycardia, rarely, I would just add there, rare orthostatic, you can have that. You can have rare orthostatic hypotension, as you said in the studies.
So orthostatic intolerance, orthostatic hypotension, meaning your blood pressure drops.
Right.
I'm sure you're more familiar than I am with the camera study. Right. Very, very few patients have orthostatic hypotension, right. Which means the blood pressure actually drops.
Right, but they can have it. So just put a /rare, like that.
Good, yeah.
That's one point.
Yeah.
So also the norepinephrine levels. So once people are symptomatic, the current postule, you're saying,
yeah.
like we're speculating, why do people have, the structure versus function? So the idea is that it's change in receptor sensitivity. So the symptoms, once you're symptomatic during the migraine and you have, the syncope or you have the feeling of dizziness, your norepinephrine levels actually go down, in the studies. So the whole idea.
That's interesting. I didn't know that. So during a migraine, your norepinephrine levels drop?
So we'll have to look more with John into that, but from the studies that I looked, the kind
yeah.
of postulate is that what happens is during the time you don't feel good, you quote unquote drain your norepinephrine, so your receptors are more sensitive. So in the studies, initially if you give phenylephrine, you have increase, blood pressure for longer sustained
yeah.
periods, but then you quote unquote, the current explanation. Again, we're
Yeah.
always with the receptors, modulation. That's what we're calling. We're trying to not call it increase, decrease
Yeah,
anymore
yeah.
in neurology and
Yeah.
psychiatry, because who knows in the different
Yeah.
spheres of neurology. But currently, we said in one of the slides that I have from the addressing the dizziness and those symptoms, the kind of postulate is that during the time you don't feel good, you drain your norepinephrine and the dopamine increases, and the dopamine then causes the symptoms of.
So I knew about the baroreceptor
Right.
change during migraine,
Right.
but I didn't know that norepinephrine levels dropped during
So I'll
migraine.
Have to look,
Yeah.
I'll have to look into that piece.
Circulating norepinephrine levels?
I'll have to look, I have to see, I think I'll have to look, John, how, they were doing, because we don't usually check. That's, it's not standard
Yeah.
of care, it's done for research.
Yeah,
It's not
right.
standard of care that we check.
But that would be
actually,
very, very interesting. I'd love to see that.
Yeah, neurotransmitters, right, during the time,
Yeah.
they have them. So we would then have to discuss how we want to do.
So for sure your baroreceptor gets reset in a migraine period, and you get less sensitive to phenylephrine.
Yeah.
But, okay.
So, but migraineurs outside of the, when they were studying for phenylephrine, on the studies that were done, they were more sensitive to the phenylephrine. It was sustained, more prolonged, and more increased blood pressure.
Yeah.
It was only in the people who were more sensitive to then having clinically syncopes, like fainting spells. So there's like very small subset of people.
I'd love to see that study. That would be very instructive.
Yeah.
With the headaches, are you referring to like the classical migraine, or kind of just all people with headache
Headache.
complaints?
So I was talking about migraine. So
Okay.
I wasn't talking because most people with autonomic dysfunction, all of them have neck pain.
Mhm.
That's pretty much guaranteed. 90% of people will have neck pain. Now, people with migraines have both, frontal and neck pain typically. And the people who have autonomic dysfunction will have not only the frontal, but more of the neck pain as well.
Okay.
So that's kind of.
So this just summarizes the concept. Structural is a defined change in a structure produces disease like multiple system atrophy, diabetic autonomic neuropathy, and you can go on. This is just examples. Baroreflex failure due to neck radiation, and that's akin to a hardware failure. Functional, change in autonomic nervous system function is involved in the disease production, not as well defined, and probably some sort of a link in a pathogenic chain. So we've got examples of that: postural tachycardia syndrome, irritable bowel syndrome, syncope, and just make sure, sometimes doctors use the word functional to mean non-organic. That's not at all. This is being functional as opposed to structural. So it's a software issue. Now, this comes back to what Natalia was saying, which is really not an absolute. It's a conceptual framework. Things move back and forth between structural and functional. As we gain insight into what functional is, we may eventually sort of think about, well, it's an immunologic issue. We may begin to understand it as a structural disorder. The classification then overall would be, you've got the general dysautonomia category, you've got structural, you've got functional, and within structural, then of course you can localize the disorder. Whereas within functional, since we don't know what the autonomic nervous system is specifically doing, it's really hard to figure out whether it's a peripheral or central disorder. And these are just examples. On the peripheral side, you have pure autonomic failure, small fiber neuropathy with various types of etiologies. Central, multiple system atrophy, Parkinson's. And Parkinson's is a line across the small fiber neuropathy just because there's increasing clear evidence that there is a neuropathy in Parkinson's and that Lewy bodies do invade the peripheral ganglia very clearly.
Where would you put chronic fatigue in this at this point?
Chronic fatigue would be over, for me, on the functional side, right.
Okay.
Yeah. If we think about the three orthostatic syndromes, orthostatic hypotension defined as a drop in blood pressure, 20 systolic, 10 diastolic in 3 minutes. There's a little cartoon there to show the blood pressure heart rate pattern. The primary physiology of orthostatic hypotension is a problem with the innervation of the blood vessels usually. So the main impact is going to be diastole with systole following. So that's why you have orthostatic hypotension, which is the white line going down. Cardiovascular reflexes are usually going to be abnormal in that group of patients. And as a structural disorder, it's generally got a poor prognosis. Postural tachycardia syndrome is defined as an increase in heart rate of 30 beats per minute in the first 10 minutes of a standing or a tilt. By definition, there can't be any drop in blood pressure, otherwise it would be orthostatic hypotension with a compensatory tachycardia. The physiology relates to central venous volume or venous return. We think that's one of the reasons people with Ehlers-Danlos or elasticity may get this. And it will impact systole much more than diastole. If anything, diastole may actually come up sometimes so that you wind up with a very narrow pulse pressure. The cardiovascular reflexes, meaning cardiac response to deep breathing and Valsalva maneuver, will usually be normal. And it's usually seen in the functional group of disorders. So it's got a much better prognosis when we talk about longevity. And reflex syncope is a sudden drop in blood pressure and heart rates. It's a threshold issue. So it's normal. Anyone will pass out. So 100% of people, if you put them on a tilt table and put them in a lower body negative pressure box, they will pass out. So it's a normal human reflex intended to stop the brain from functioning if you have a major bleed or something like this. So it maybe puts you down, but the abnormality is that it happens at the wrong time. This is to point out how little patients with structural disorders can sense their symptoms. A study we did some years ago looking at patients with typical symptoms and patients with atypical symptoms. This is the supine pressure and the standing pressure in this group who had typical symptoms, meaning they feel lightheaded. This study was done during the tilt table, so we're asking the patients minute by minute on the tilt table, what kind of symptoms are you experiencing? And so we had about over a couple hundred patients who wind up with very profound drops in blood pressure where their nadir, I think we required a greater than 60 millimeter drop in blood pressure. So we were not looking at people with like minimal drops, big drops. And we looked to see how many actually had no symptoms, and fully a third of patients had no symptoms at the time their blood pressure was about 80/40 compared to a supine pressure of 160/75. And there's really not much difference in the pressures of the ones who have a lot of symptoms and the ones who don't. The atypical ones were like toe pain, abdominal pain, things that you wouldn't usually relate to having orthostatic hypotension. So point is that patients with structural disorders often are not aware of these symptoms.
And how much do you think you could account for that by changes in cerebral autoregulation?
It's a great question. The theory has been, amongst autonomic specialists, say, well, okay, they've had this for years, their brain is autoregulated. But I don't think that can be true for everybody, because many of these patients suddenly go out. I mean, they're on the tilt table, you're watching them, and then their pressure goes 80, 75, and at some point they hit 70 or whatever their threshold pressure is, and they go out and they never ever got a symptom before they go out. So and so clearly they should have had a warning. So I don't think, Paul, I'd be curious what you think.
Well, I think that the point of the autoregulation was the one we've always speculated, tried to prove it with Wolfgang when we did the study on autoregulation, and the data is kind of not 100% clean, as Tom was saying. So I think there's a combination. For sure, if they develop the symptoms fast, such as acute autonomic neuropathy, they generally are symptomatic big time. These patient things evolve slowly, and I think two things happen. One is there is a certain correction in the autoregulation curve, but the other is their brain sort of desensitized to the symptoms, for lack of a better term. And so they don't recognize it. Or the area of hypoperfusion involved the area of awareness before others. So it's a combination of things. So no, I'm fine. You don't get the pressure. You finally put the patient down on the table thinking, geez, can't even measure the pressure. How long am I giving the patient brain damage? And you say, no, I'm fine. And then poof, they pass out. So I think it may be a combination of things. But it's a very interesting phenomenon.
So kind of follow up on John's question. So there is no question probably that we have some homeostatic reset. There is more literature on this more than anything in weight gain. So your body needs to stay in the same weight for about 2 years to consider the new weight,
normal,
the new normal weight. So
the question would be, there's no question if you have them prolonged, something for the body that it cannot change for a prolonged period of time, it probably becomes the new normal.
Correct.
For the body. So it's kind of like you have a reset, homeostatic reset, point, and then so the body goes, okay, I've been doing this for an interesting point. We don't really know how long do you have to then stay in that new state for the body to accept, okay, I can't change it. I'm not going to give her alarm or him alarm
Exactly.
because it's the new norm.
But the question is what? So why do functional disorders tend to
Right.
get worse and worse over time?
They
They're
don't.
more and more sensitive to
Majority-
symptoms.
The majority of our patients that we see in the clinic, in the migraine clinic, improve dramatically. And once we get them into improved with their headaches, they usually improve with all the other functional things. I've seen many people over time have gone to the ER weekly with, fainting.
But I'm talking about untreated. I mean, the MSA patients are untreated, and the functional disorders. So untreated, the two disorders go in the opposite directions.
You say that functional disorders become, can you just rephrase it?
They become more sensitized over time. So their symptoms, an untreated, so they'll take to bed and stop functioning.
Well, because you're doing that, you're not, the self-regulation of treatment of people is missing the points that you need to treat. So I would argue that 90% of the things that we're doing, for people who have functional disorders. So if you feel tired, your natural tone is going to be to sit or lay down. But
No argument. But the issue is what's intrinsic about the structural
Well,
versus the
can
functional.
I finish? So if
Yeah,
you
go
can
ahead.
then get people, gradually, graded activation, and you have to convince people because they feel horrible, terrible, they have low energy, they don't feel like doing
Yeah.
anything. So you have to then have incredible power of trying to convince the people that indeed, in order for you to feel better, you will actually have to move, you will have to exercise, you will have to do the things that you don't feel you want to do. Most of those people then can really dramatically improve.
No argument. And you'll see that's exactly what.
Physiology is exactly what you had in the other slide.
Yeah.
So the organic structural ones they have a high threshold, and the threshold becomes higher and higher as they
Right.
progress. The functional disorder are
Right.
typically low thresholds. Again, nothing
Right.
is filtered, and they get lower and lower. So that's what I think in my mind is the reason
It's
for
very
the
interesting.
divergence.
So what you're saying is that people who have a problem with their function receptors become even more sensitized over
Correct.
time to realize how badly they
It's the
feel.
same for the chronic pain patients. They become more and more
Sensitized.
sensitized.
Right.
So you think that should happen the other direction, but it's a.
They don't get used to it, that's what
There is a.
So I guess.
Divergency, pathophysiologically,
Yeah.
that
Right.
is really
So I think they diverge from a fundamental path. So in both cases, you're going to try to manage them, right? But the management for functional disorder is exactly what you described. Why? But you don't need to do so much in structural disorder from that perspective. You need to do many other things. So.
And I would maybe say, Tom, that what we were taught, let's say 10, 15 years ago, and still many people do, is not maybe how we should approach, some of this. Because again, as you said, okay, you have the set point. Maybe we need to be working, on figuring out, okay, can you reset it and or not? And you're going to be much more likely able to do that, and the function changes. The question is, if you have structure, how you were using, I use the same comparison, the hardware versus software. I would argue that if you have then the hardware problem, automatically you'll have software problems. So in people who have the structural disorder, they have some overlay of abnormal function going from that structure. And
Yeah.
how much is abnormal just from the structure, how much is abnormal because then they're less activated, do less, exercise less, like
Yeah.
mitochondrial disorders. I have patients who will say, no, I can't exercise because I have mitochondrial disorder, and the research goes against
Opposite,
that.
right,
Opposite,
opposite,
that.
yep,
So
yep.
it's kind of a very interesting point.
All right, so the only point I'm making here is in structural disorders, if somebody has a fall, it's probably worth doing a tilt table test, or at least doing orthostatic pressures. And just because you think you understand what motor and sensory neurologic issues may be contributing to a fall, doesn't mean you shouldn't also check orthostatic pressure. And just hypothetically, I don't think we can demonstrate this yet, but hypothetically, you'd think that the part of the nervous system that is most close to failure is the one that's going to fail if you make the brain hypoxic. So I think that at least that's one thing you can help people with, is to improve their pressure. So is this a central or peripheral disorder? Clearly you've got memory loss, Parkinsonism, falls, and very few peripheral complaints or findings. So the possible diagnoses would include Parkinson's disease with diffuse Lewy body involvement, multiple system atrophy, or maybe a multi-infarct Parkinson's with dementia. And this just covers some of the prevalences, which I think really the only point I want to make is that Parkinson's disease is about 1,000 times, 500 to 1,000 times more prevalent than multiple system atrophy. So if somebody shows up in your office with orthostatic hypotension, even though orthostatic hypotension is far more common in MSA, chances are they may just have Parkinson's disease with autonomic dysfunction. And vascular Parkinson's disease is about halfway between MSA and Parkinson's disease. So this is the guy again. What do we think he has? And this is the point of this slide, is just the prevalence. So if you look across, this is a very nice work by Bonicelli. It was done more than 10 years ago. But the prevalence of OH in patients with MSA is pretty high. But if you look at all patients with OH, just because this is the group with PD, the person is just more likely to have PD. And that's been my experience. So just one word on small fiber neuropathy. And I think just about all of us here are neurologists, so we know this. But we have this funny terminology, small fiber neuropathy and autonomic neuropathy, which really doesn't make that much sense compared to large fiber. In large fiber, we say you have a sensory neuropathy, you have a motor neuropathy. And we should use the same terminology in small fiber. So a small fiber neuropathy infer sensory. That means they have a small fiber sensory neuropathy. And an autonomic neuropathy really means a small fiber motor neuropathy. And of course, a person can have both. So this to me is much more parallel terminology. And I'd rather use small fiber motor neuropathy and small fiber sensory neuropathy, or small fiber non-discriminate neuropathy, meaning they have both autonomic and sensory. And that's just, it's sometimes very confusing. Okay, so I want to talk a little bit about the comorbidities that occur in functional disorders. I'm going to present a different case, which is a 24-year-old woman, lightheaded upon standing for 3 months. She's an athlete. She's continued graduate school, but reduced her daily running to twice a week, about a quarter of the distance. She fainted once when her symptoms began, but learned to sit down or lie down when symptoms became severe, so she's not fainting that much anymore. Primary care physician was very good, added salt to her diet, so that helped a lot. She's not on any other medications, and her examination is normal, except that she has a blood pressure of 120/70 with a heart rate of 56 lying. Remember, she's an athlete. And when she stands up, her systolic drops a little bit, diastolic comes up a little bit, and her heart rate goes to 95 blood beats per minute. She's lightheaded at that time, and she has a basic evaluation, which is okay. And so again, we ask which organ systems are affected. I don't think I gave you enough information to answer that question. So she's actually had, Natalia, migraine headaches since age 14, much worse since it started. She had irritable bowel for the last 6 months. She's had a frequent nausea with a 5-pound involuntary weight loss, and unrefreshing sleep for 2 months, along with chronic fatigue. So we'd say based on this, then she's got something going on in the upper and lower bowel, something going on in the cardiovascular system, and tell me if this is not typical. Family history, mother, sister, and 3 maternal aunts with migraine. This is a completely true case. Mother has IBS and fibromyalgia. Do you guys have family histories of things in your family? No?
Nope. My mother she just was the restroom.
Okay.
My mom has cancer, but I am...
No IBS, no...
My mom has IBS.
Okay.
And then my maternal aunt has Raynaud's, and I have Raynaud's.
Okay, how about migraine?
My mom has migraines.
Okay. So that's what we typically see in a family history. So migraine, 3 maternal aunts with migraine headaches, sister, maternal aunt, and 3 cousins with POTS. 1 sister has pelvic pain, was diagnosed with endometriosis. And if time allows, I'll come back to endometriosis because it's actually given us a lot of information about what happens in the brain. and one sister with a generalized anxiety disorder.
So they actually had a study where all of those go together, the migraines with typically fibromyalgia, irritable bowel, anxiety, depression, and one of the kind of connecting things, we're not, genetically very astute yet, but catechol-methyltransferase polymorphisms kind of tie all of those together in many of the families, so they have all of those.
Yeah. There's a lot of papers coming out
Right.
in terms of
Right.
different things.
Right.
That's
Right.
some opiate polymorphisms as well. So is this a structural or functional disorder? So this would be fall on the functional disorder. Software more damage than hardware. Brain networks report many symptoms beyond just POTS. Few abnormalities on exam. And is this central or peripheral? Just asking the same questions we asked with structural disorder. Well, usually it's non-localizable. Some patients with POTS and fibromyalgia may also have a small fiber neuropathy, and I don't know if you've been following that literature, but that's coming out as well. The neuropathy's been given causality, but there's no evidence that's true. There's no evidence that.
I have a colleague, Leo Wang, who's John's colleague, who has been doing the biopsies.
Yeah.
And he has found in many patients who have, especially that fibromyalgia, he finds, as he said, the
Yeah.
small fiber or
Right.
autonomic neuropathy.
Yeah, you just don't know what that means.
Right.
You don't know what that actually.
Most people like it because then they have something that is quote unquote real, because they see so many providers who tell them it's in the
Yeah.
head instead of in the brain.
But-
It's not published, right?
The fibromyalgia, small fiber. You should.
There has been a few, because I
Yeah.
just did a full search for the paper we are writing.
But
There was
didn't
an
you showed
Italian
me?
paper
Yeah.
that
Are you writing on that?
Well, we find out that patients with myofascial pelvic pain
Mhm.
versus interstitial cystitis have
Mhm.
much more autonomic neuropathy
Mhm.
and fibromyalgia than the IC patients.
Mhm.
So that paper is, we are just sending it for submission, and so I was reviewing the literature trying to put together the autonomic neuropathy with the fibromyalgia and realize how little has been written.
Right.
And we had a lecture given by a Spanish guy whose name I've forgotten.
Spanish guy living in England.
Yeah, Spanish guy living in England. About a year ago, in which he demonstrated clear abnormalities in the function of the small fibers in fibromyalgia. But again, I think the issue is we're still talking about software because we don't know what's the chicken, what's the egg. What?
What's his last name? Jorge.
Yeah,
Jorge is his first name.
Yeah.
And, I think my experience has been that early on, I was really following up normal QSAR studies, sometimes with biopsy in patients that I thought
Abnormal.
clinically
Or normal.
normal. Actually, I started following up abnormal ones as well, but having a neuromuscular capacity skin biopsies, and I actually didn't find it helpful. We found a few people that were abnormal, but when they were normal, I was never sure whether it was a sampling error, that they still could have a patchy neuropathy that you didn't see. And then had some discussions with Steve Waxman when he came out and talked about this SCN9A mutation.
Erythromelalgia, right.
Sort of, like we were saying, sort of a hypoexcitability of peripheral nerve that gives I'm kind of not sure where to go clinically with that, whether it's worth, how hard do you look for small fiber neuropathy? QSAR's normal, everything else is functional. Do you pursue that further?
Well, we have done, with Adam Lowenbrook, he did his thesis, for his master, on looking at, we took biopsy from patients sweating, actually, on TST. We had a normal sweating and abnormal sweating, and we really couldn't find a one-to-one correlation. And I think there are multiple levels of that. One is you can still have only a somatic neuropathy, not an autonomic, and vice versa. The second thing, I think, frankly, skin biopsies assessment is a bit overrated. We forget how huge variability there is between different areas of the body, between different people, etc. The actual first person who did, like to his credit, skin biopsy was Peter Dick many years ago. And he abandoned that because he didn't think it was worthwhile because of the large spectrum, etc., variability, etc. So you give that. Then Bill Kennedy made his career really out of it. And now everyone is doing skin biopsy, and I think it needs to be put in perspective. It's the typical things that you have to use as a piece of the puzzle. And I really dislike when people come and say, oh, I've been told I have an abnormal skin biopsy. It makes no sense whatsoever clinically, you don't know what to do with it. Sometimes also can be relatively, doesn't take much. I've done a skin biopsy a little bit myself, and really if you don't handle the specimen properly, the nerve fiber disappear. Or if you don't use the right fixative right away, there are so many levels. But even when you do it perfectly well, there is this huge issue of the variability and the issue also of how to quantify properly, particularly for the structures that we're interested in deeper in the dermis. And again, even listening to the papers in stress, I still hands down to Adam, to the effort that he put to do the calculation. That's so time consuming. It's honestly, at the moment, I would say absolutely impossible to consider it for the clinical practice. And I think we're cutting patients short anyway. To me, the idea that fibromyalgia is a small fiber neuropathy, I just cannot, in my mind, wrap my head around it. I just cannot. I find it made more sense when there were a study done on the CSF showing some metabolites, the shift again, and all those data still very soft, of course. It's like, what's the chicken and what's the egg?
Can I ask one question? So I have not, we have again a colleague who has been doing more of them, but I would be interested to know just what plain deconditioning, because a lot of people get deactivated, right? So we know with aging we all lose, nerve fibers,
right.
Genetics and environment. So what would it look like if you, let's say, for whatever reason, are in wheelchair, right? You don't have any other option, you don't feel good or whatever, you're reading. What happens to the deactivation? Do we then lose nerve fibers from deactivation? So that, like taking someone who doesn't quote unquote have fibromyalgia, but for whatever reason comparing, if we have just someone 2 or 3 months in a wheelchair, would that then cause, atrophy and, decrease, in the nerve fibers that then would clinically look like?
I don't think anyone does that.
No, we've been talking to Ben Levine about doing a study like that. So Ben Levine's a guy down in Texas who does this. He puts athletes at bed rest for like 3 or 4 weeks.
You're kidding. So I've heard of that, but I didn't know that someone was doing that right now, that it would be even considered ethical.
No, he's doing it to study outer space, so astronauts and this kind of thing. He's doing microgravity. And what he told me was that his subjects are, these are tough athletes. So he puts an art line in them and does all kinds of instrumentation, and they're not even aware of it. And after 3 weeks of bed rest, he's re-instrumenting them, and they're so sensitive, so queasy, they cannot handle any of this. So we've talked about just doing some pain. Pain. So just and we know that
It would be brilliant to do, everything you could do,
right.
all of the neurotransmitters and everything, right? And
well, at least just go down and do some pain sensitization, quantitate how they're pain sensitive, do some small fiber testing, and compare pre and post.
Because then the bigger picture again is are people then having symptoms
from the disease themselves, or because of the disease is causing you to get into that state.
Exactly.
So
that's exactly the point.
You're talking about like a chicken or the egg kind of thing.
What I'm talking about is, a lot of people, when they don't feel good, the natural tendency is going to be for you to withdraw from activity, and be more sedentary, or stay more time in bed, not be as active. If you're forced and being in bed, let's say for 3 weeks, and you're completely normal, you have 0 symptoms, will you feel horrible after 3 weeks of bed rest? And I would argue yes.
Yeah.
So we currently, are we helping people with, giving assistive devices? In the old days you didn't have wheelchairs, right? Are we
causing more problems, from doing that. Like I see that a lot of it, let's say MS patients, the current, norm is, you don't feel good, so okay, I don't feel good, I'm going to use a wheelchair, right? I'm going to, is that good for you? Or should you be forced to walk as much as you can or exercise as much as you can? And we don't know that, no one knows that in medical, but in the old days, we used to say, okay, you don't feel it, just sit or lay down. And I would argue that for sure, if you have functional disorders, absolutely it's a no-no. And the structural, I don't know, because we don't really have any studies.
Well, actually, I have a patient without a formal study that are terrified because they learned that staying active is the only way for them to remain semi-functional. And then they have to have surgery for unrelated condition. They're scared to death. Oh my God, I need to have my knee replaced, or I need to have my colon.
Yeah, if something goes wrong with me and I have to quit doing what little exercise I can do, then yeah, it's like having to start all over again.
Right, exactly, and that's true. And I can say that when I had my foot surgery, I'm a runner, right? I was more sore doing nothing when I was in crutches and trying to hobble around those things because I was driving me crazy. But I think there is a true thing about the endorphin withdrawal that when you're used, and I think we see this in athletes, that something happened, I cannot do it, and all of a sudden that whole body pain, and these were people that were doing brutal things, triathletes that do insane stuff, you think, oh my God,
Brittany, you gonna say something?
Yeah, I was a state competitive swimmer. I was a state athlete before I got really sick.
Sure.
And when my doctor, then my POTS specialist was the one who was like, for your safety, we need to put you in a wheelchair because I was fainting 25 times a day, plus seizures and everything.
Well, but you're in a manual wheelchair. You're still getting exercise.
I'm still getting, and I don't let it hold me back. Like I still adaptive ski. I still do things, like I'm one of those people where I'm like, I adaptive ski and I just let my instructor know, hey, I pass out and have seizures, but should I be doing it? Probably not. Do I do it? Yes. But it's just also part of the patient's personality. And are they going to let their illness hold them back? Are they not going to let their illness hold them back? I truly believe that a lot of it's mental, as well as physical. Do I spend weeks in bed at time when I can't get out of bed? Yeah. Because I do, but I still have symptoms when I'm in bed.
Right. And this discussion is not to make you, feel bad, or it's not intended to do that. It's just trying to figure out what are the right things that we, come and people come to us for advice, and we want to give them the best advice.
Of course.
And are we giving them the best advice? So
no, of course. I just wanted to give you my perspective.
Yeah, it's great.
Experience. Very much appreciated. Yeah.
It was like the worst. Being told I had to be in a wheelchair. Like I saw it because I loved being active, and all I wanted to do was go back to swimming.
We're just having a very informal discussion.
Right now, informal till it starts up again.
Well, I can't swim anymore because I have my port, and I'm on 24-hour infusions, or 8-hour-a-day infusions, and I'm constantly accessed, so I can't even swim anymore.
Something the lady in pink, Paula. You mentioned, okay, and this is a layperson question here, but you mentioned people talking about fibromyalgia and small fiber neuropathy as if they were kind of the same thing. But I was under the impression small fiber neuropathy was actual damage to the nerves and deactivation. The nerves weren't working right. And I was under the impression fibromyalgia was the nerves kind of being overactive, being too sensitive.
That's
Am I off on that, or?
Different things you can answer for.
Well, my perspective is exactly, there is no question with fibromyalgia, the thresholds are low. That's why. So if you think of small fiber neuropathy, you can have actually, if you have true small fiber neuropathy, you may have patients that are still sensitive if the fiber is not completely damaged, but the fiber is angry. So pre-damaged, but sort of irritated.
Okay.
And then, on the other hand, we have patients with small fiber neuropathy that are insensitive. So is this just, again, in the spectrum? And I think the jury is still out.
So the analogy that one of my colleagues uses, and that might help you, is that ultimately it's your brain's perception, how much pain you perceive. So what happens probably both with small fiber neuropathy is you lose, the nerve fibers, your thalamus, the executive secretary kind of amplifies the signaling because it's getting less signals, so it has to amplify it, so then you feel it, more.
Okay.
And sometimes in fibromyalgia you have the same thing where, people, touching or, pressure that shouldn't cause pain causes extreme pain. So again, you have the same amplification of the signaling of your alarm that shouldn't probably give you pain when someone touches you, but yet it's amplified.
Okay, that correlation makes
So
sense.
you have central amplification of pain. Okay, that makes sense.
Okay, thank you.
Okay, so this is a example of somebody who's got POTS. It's just a simple tilt table recording, and this particular person obviously also passed out. This is the patients that we're talking about. So baseline, then they're tilted up, and notice there's a lot of change in the variability in the blood pressure, but the diastolic really never drops until the point where they're getting ready to pass out. The heart rate goes from about 70 to about 100, 110. In the first 10 minutes, it hits about 120, and then continues on up for the remainder of the study, which lasts about 15 to 35, 23, 24 minutes. And at this point, the person passes out. They also get a bradycardia, so they have syncope in the setting of POTS. And then this is a definition of POTS, which is, I think everyone in this room knows this, so we'll skip forward on this. And it's increase in heart rate of 30 beats per minute in the first 10 minutes, 40 beats per minute if you're less than 18 years old.
I actually have a question about the definition. Yeah. The woman who I'm actually replacing, who is supposed to be here today but was too sick, I think she's seeing you later. She has POTS. She has the 30 beats per minute between lying and standing. But regularly, she's not tachycardic. Like, she's actually leaning towards, I would almost say, bradycardia, because, her 50, 60, whereas with me, even on beta blockers, I'm doing good to get it into the 80s. So, yes, I'm just asking, how, I wanted to ask on her behalf, how does that work? Because she seems to be the only person in our little POTS circle that is like that. The rest of us are just tachycardic all the time, and then, we're, 80s lying down, and then without medication, I get up into the 160s when I'm standing. And when she's resting, her heart rate's actually dropped into the 40s before. So is that normal or abnormal for a POTS patient?
Well, what I would say that's not part of POTS, but it can be part of what we might consider as autonomic instability. So sometimes the vagus might be producing a lot of input. I'd have to it's hard to answer in the abstract. You have to kind of see what the pattern is, and is this only when she's lying flat or also when she's standing up? There's a lot of...
It increases, it'll increase, but it increases to 70 or 80 when she's standing
Sometimes.
up.
And other times it increases more, or just...
No, her heart rate stays pretty low, but it is increasing that 30 beats per minute.
I'm going to show you some maybe a little bit surprising information that actually doesn't really matter in terms of how much your heart rate increases, because what we call orthostatic intolerance, which means you
Don't tolerate.
You don't tolerate being upright, exactly, but your heart rate doesn't actually increase, have the exact same pattern. You have the exact same number of comorbidities and the same severity of symptoms as people whose heart rate increases.
So we're not really, in answer to your previous question about fibromyalgia and small fiber neuropathy is a great question. To be honest, I think we have to say we don't know. We just don't know. And right now, I would say we're getting more and more to the point where with POTS, at least the group who have all these comorbidities and are hypermobile, which may be a separate group, but that group, I would say we don't know. We just
don't know where is that coming from. I'm going to make an argument that it might be coming from the brain, but that's just an argument. It's not a thing.
Yeah.
So we talked about these things. Right now, I don't think we can classify POTS because we just don't know but these are things that have been used. Neuropathic POTS meaning the person's got a neuropathy with it. Immunologic POTS meaning the person wound up with an infection right before the thing started and it kind of looks immunologic. For a while, the anti-ganglionic antibodies looked like they might be elevated in some patients, but that didn't pan out. So when we look at that group, they never really go very high, and it's never been clear that some patients with the so-called immunologic POTS clearly respond to IVIG. I've got one patient. In my whole practice of probably, I would say I've got 500 patients who've got POTS. One patient that I'm convinced responds to IVIG of the 500. So that's 1 out of 500. So there are cases where clearly there's an immunologic, well, at least in my mind, I mean, it could be, I'm wrong, but in my mind, this person clearly responds to IVIG, and this has other autoimmune issues going on that are very clear cut. So, but I don't know, I'd be interested in others' experiences.
I generally don't think just for POTS IVIG is just
Right.
I think these people that are neuromuscular group that had considered doing IVIG and or they just felt like they got a little bit of response. To me, it's very hard to dissociate the benefit that you get from that high volume load. It's the onconic load from all that,
Yeah.
that protein, and everybody feels better. So
Right.
how do you?
Well, there is, I mean, this is a very soft argument, but if IVIG is really working, not as a volume expander, the person should be better 10 days, 2 weeks down the road, not better immediately. And that's what at least this particular patient is. If it's a volume expander, they just get better for the 4 or 5 days, and then it's just a volume issue, right? So, I mean, it's a very soft argument.
If I had a hyperacute onset, a few times I've done IV Solumental, which at least is cheaper and has a steroid advantage to it. And I had a handful of cases.
Yeah.
But I really like
Bottom line, very, very soft call on this immunologic thing. Hyperadrenergic POTS, that was used for a while, meaning that the norepinephrine levels rise a lot. We do see patients that way. Is that actually a subgroup? We don't know. Associated with hypermobility, the theory there would be that you have venous distensibility as well, because the same elastic tissue that makes your joints makes your veins, and so the veins don't recoil properly when you stand up, so you have POTS. But then why would the POTS come on fairly abruptly? Wouldn't that be a whole life kind of experience? I mean, so these patients typically will have been fine for years, and then all of a sudden they develop this. So something happened on top of the hypermobility. High flow, low flow, that's what Julian Stewart uses. He's popularized that character. Some patients have high flow, some patients have low flow, some patients have intermediate flow, and there are clearly differences in nitric oxide and angiotensin and other hormones. But where's the cause, where's the effect? It's just not clear. So these are all classification schemes, but they're not very helpful. This is something we did a long time ago, looked at the patients that seemed to have neuropathic POTS versus the patients that didn't have neuropathic POTS. And the only difference was they had more headache and more GI symptoms. I really don't know what that means. So here's some other functional disorders, just not a exhaustive list, but some non-painful disorders and some painful disorders. Notice that the majority of them seem to have pain associated with them. And you could argue, and I wouldn't argue against you if you told me, well, this doesn't belong in there. I said, okay. It's just a group of disorders we tend to see go together. This is Paula's publication from, were you around in 1999? You just are too young. You couldn't have been around. And these are some of the other comorbidities that we've seen, some of which I mentioned, fibromyalgia, hypermobility. So it's very curious. I mean, we think about Parkinson's disease, it doesn't come with a whole set of non-explainable comorbidities. You think about ulcer or congestive heart failure, the comorbidities seem logical, but in this case, the comorbidities, at least we don't have a good explanation for them yet. This is a pediatric population that we published. I think, I don't remember how long ago, maybe 5 years ago. Sleep disorders are extremely common. Non-GI chronic pain, GI pain, Raynaud's-like symptoms, recurrent nausea, vomiting. Headache is very common. Syncope is very common. And then urinary symptoms in the pediatric population are less. In the adult population, there are more. If you look at it coming from the other side, functional abdominal pain, it's almost an identical picture. So it seems like these are two sides of a similar presentation. So the one thing I would say regarding management of functional autonomic disorders is to stay away from symptom management, meaning somebody says symptom A and you manage that, and symptom B and you manage that. Rather, and I'm not saying anything new, the whole conversation here has been talking about this. What you want to do is you want to activate the person. So how do you activate someone? You activate them by, first of all, get them off the medications that could be problematic, and typically those would be opiates or benzodiazepines that are inactivating medications. And you do the best you can to get them into the most vigorous exercise program gradually that they can tolerate. So I would say this is the cornerstone of the management of functional autonomic disorders because of this incredible overlap we have between deconditioning and functional disorders. So we may not be able to impact the functional disorder itself because we don't really understand it yet, but we can impact the deconditioning piece of it, which at least will take away whatever role that's playing, which I think is going to wind up usually being 50, 60, 70%.
Have you found a specific exercise regimen or approach, or someone's studied that? What's the best way to...
So the question of whether exercise works or not has been studied by Ben Levine, and he's shown actually physical increases in heart size. He's shown that people with POTS tend to have a small heart, an increase in heart size with exercise. But they'll admit to you, they'll say if you talk to the patients, they don't say they're healed. They're not 100%. They're just better than they were before. I often, this is just experience, I start with a water jogging program. I start with a water jogging program because patients often can't tolerate much more. So they've been really deconditioned. And so if I can get them, and a lot of physical therapy places offer a water aerobics program that starts gradually. The thing about the water that's so helpful is that it's anti-gravity, so you're really in an anti-gravity suit. And so you don't have the orthostatic complaints as much. And then you also have a wall of water against you, so it's intrinsic resistance exercises, which is what they need. And core building, which is also really important. And then after a month or two, try to move them out of the water, continue the water, but move them out of the water, get them into a core strength building program. I encourage Pilates, a lot of Pilates, and ultimately upright exercise. And then you saw from before that sleep seems to be the big, so let's see, sleeping issues, 60% of functional gastrointestinal disorders and 90% or more of patients with POTS. So addressing sleep is very important. I would say a good 50% of people, unfortunately not more, but I would say a good 50% of people respond to a very simple tricyclic. And I think people are afraid of the tricyclics because they got all side effects and you have to get an EKG to make sure there's not a prolonged QT. But I still think when a person tolerates it, which is about half, it's the most effective type of drug available. And if you don't want to worsen, so amitriptyline is still really effective, but I use doxepin first only because it's got less in the way of orthostatic issues associated with it. And you don't use a lot, start with 10 milligrams. Some people say, okay, 10 milligrams just wipe me out. So fine, okay, let's go with pediatric doses. So you can actually get 1 milligram suspension and go with that. And increase it gradually. I would say on average, people maybe need 30 or 40 milligrams. On the other hand, there are these patients who have these really bad upper GI issues, and I'm quite sure they're not absorbing because when we do a 24-hour urine sodium, putting them on the usual doses, which would be about 6 grams of sodium a day, there's very little sodium they're excreting. So I'm not afraid to go very high using doxepin, but checking levels and checking EKG. Very high, I mean 200 milligrams. But that's assuming that the person is not having side effects, obviously. Cognitive behavioral therapy is really important, dealing with stressors, impact on life, just figuring out, sorting out which are the consequences of psychological issues, which are the cause of psychological issues. And then I'll often use an anticonvulsant like a gabapentin or Lamictal or whatever is needed for, particularly if there's a lot of migraines. I really like topiramate. I think it works really well.
So staying here, what do you think about SNRIs? Like Loxone?
I think they're very helpful. They can be very helpful also. I much prefer the tricyclic if they'll tolerate it because of the sleep effect. I think the sleep impact of a tricyclic is better. But if they don't tolerate it, I think SNRIs can help. Remember, some of these patients have so-called hyperadrenergic POTS, so they're raising their norepinephrines like crazy when they stand up. If you add an SNRI, then you're going to produce
That's
even.
in effect, I mean, amitriptyline is SNRI.
Yeah, but it doesn't have the same impact. So if I do lying and standing norepinephrine levels on somebody with amitriptyline, they'll not have much of a bump. On venlafaxine or Cymbalta, they may be 1,000. I mean, so it's like a 10-fold increase. So this really specifically targeted.
What about beta blockers?
So I joke around. I think beta blockers for migraine are great. I think beta blockers for POTS treat the doctor, not the patient, because the heart rate looks better. But if the patient tells you they feel better, so in general, I think if you need a beta blocker, they're not getting enough salt. So I would first make sure. So from my perspective, I used to think that you needed 170, and I'm actually coming to that, but 170 milliequivalents per day. I would say in our specialty right now, we're thinking more like 250, 300 milliequivalents per day of salt. And so I'll push the salt. If the person says, well, my heart rate's still rising, I think they're not getting enough salt and fluids. So I'd rather hit that side. I don't know how you feel, Paula, but.
I do things just a tad differently. I personally don't like amitriptyline. So
You say you do not
no. So if I have to use it, I use nortriptyline at least, so it has the least anticholinergic side effects. I've used doxepin a few times. One I've been using more and more that I like is mirtazapine, which I've put them to sleep.
I'm sorry, which one again?
Mirtazapine.
Remeron.
It's a very good drug for nausea, good drug for pain, and I think that works pretty well if the patient tolerates. The biggest side effects is weight gain.
Of all these.
Yeah?
Of all these.
So you could all.
Yeah, so,
I took most.
and Topamax, it's a fantastic drug for all the migraine and throughout the pain, etc. But I think for POTS can be a double-edged sword because the weak diuretic and the weight loss, and most of the patients with POTS are actually thin already.
Right.
So, or are people that have lost weight unintentionally, and so the loss of mass worsen the symptoms. Beta blockers, I use it very little. I use it occasionally when I think that truly the patient is symptomatic, particularly to get them started. But it's a double-edged sword because then they complain that they cannot push the exercise level because of the beta blocker, or they become more tired, which I think is the biggest issue.
I would emphasize, though, that if you're not getting at least 50% mileage or more from non-pharmacologic management, the pharmacologic management isn't going to get you very far. So you really have to focus on, and remember, we're not using this really for symptom management. Really you're looking for something that's going to help so the patient tells you, when I go to sleep, I wake up in the morning and I actually feel a little bit refreshed. That's what you're looking for.
So other than using topiramate for the migrainous component, if you use anticonvulsants, aren't you really just using symptom management? Or are you using?
No, but that is for the migrainous component or the pain component.
You said you can use gabapentin and other stuff as well.
Yeah. Well, sometimes you have an activation issue. A person has so much pain that they can't get in, they can't start their physical therapy. So as long as, at least from my perspective, you're saying the same thing, as long as you keep your eye on the prize, which is activation, you may have to use some gabapentin, but you're not doing it for the management of the symptom alone. You're doing it to manage the symptoms so that they can get activated. Yeah.
My analogy to patients is, this is your cane, so you start walking.
So what is your compliance?
You mean like Novocaine?
No, just a cane.
I use it.
So Tom, in your practice, what is the compliance with activation?
You know, like how many people?
I would say that I tell my patients in visit one, and I rewrite this discharge sheet. Exercise, slow, start at 10 minutes, recumbent, whatever, increase by 2-3 minutes every week. I write it every visit. It's almost like I cut and paste it. 2 years later, many times they show up, I said, I was looking at possibilities, and they said that exercise is important. How come you never told me? I think that it takes about, in some patients, 2 years to realize that exercise is important. You feel so miserable that you cannot even hear it as a therapeutic event. And then when finally we tried all the meds, we tried all the things all my canes to get them to exercise, when they finally realize I'm going nowhere, but so-and-so got better exercising and they start exercising, I see the drastic improvement. I have very few patients that they get from the beginning that exercise is critical. It's like it's almost impossible to hear it. What do you guys feel?
2 minutes. Okay.
Are you asking the two of us?
No, I'm asking anybody in the audience here.
With me, I got that exercise was important, and I think from what I've seen with POTS people, we generally are pretty active before we get sick.
Oh, absolutely.
Yeah, I was doing a ton of sports. The problem I had was doctors are telling me exercise, and I was telling them I can't. I'm trying. And so, yeah, the trick was first medication to get things under control so you can get started, and then figuring out how to exercise and how you can exercise.
That's a great point, and I think a lot of my time is spent creatively brainstorming with the patients.
Because every patient's different. I do yoga, but that's like a disaster.
I could swim, but it was getting out of the pool that was a disaster for me. So I have a service dog, and she alerts to my cyclical episodes. And so as long as I had her with me in the pool, I could brace, and then I just knew I was going to pass out when I got out of the pool. So I always had a friend with me who would drag me out of the pool, watch me when I got out of the pool, and I was fine.
All right, we have just a couple minutes left. Paula, you're going to cover orthostatic disorders management, right? So I'm not going to cover that in terms of salt and so on and so forth. Do you have this slide?
No, I don't think so.
This is a non-pharmacologic effect on BP. This is placebo, and then adding salts. This is the change in plasma volume and the change in time to syncope and exercise. And you can see, and the combination obviously is really, really helpful. So again, non-pharmacologic is number one. I don't think any of the drugs, mitogen, droxidopa, blah, 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 work that well or at all unless you have really put the patient on lots of salt and lots of fluids.
So I'm going to interrupt.
Yeah.
I just going back to the exercise, and I think that the movie is coming out. I had a patient, a mom, when we would go to His Autonomic International, and then we go lobbying, and so I spend the whole day with my patients usually. And this mom said to me, when my daughter got sick, my main lesson was that I had to do the opposite of what a mother wants to do for a child. So you feel sick, out of bed. Start moving. We need to go to the gym. And the answer is, but mom, I can't. Well, we have to do it. So this mom was really...
She's really good.
She was really good and opened my eyes in many ways, to tell parents, you're not a bad parent when you're giving the opposite message than what you think we need to do. And it's hard as a parent. I mean, I'm a mom. And it's hard to tell your daughter when she feels sick, tough it up, we need to get up. It's really hard.
Okay, this is the effect of tilt training. That's very, very important also. And that's simply standing up against a wall twice a day. And again, you're doing the opposite of what your body's telling you to do, which is to stay standing. All right, the question I have is whether you want me to cover some stuff that comes out of our research or not. Maybe I could cover that later. Just about so why don't we go with the patients? Maybe I need about 15 minutes or so to cover a construct of why functional disorders do what they do. And it relates to some parts, some connections, some brain connections, and that kind of thing. But I think we should stop here, move on to the patient sessions, related sessions, and then come back to this if there's time.